Okay, we should start. I hope the building doesn't tilt in this direction. There are 2 seats right in the front for those who want them. So I was told by Sarah, the first thing I have to do is tell people on the phone, we love having you, but please be on mute. So welcome. I usually have an objectives slide, but I think the title slide does that, because we're going to spend a very little bit of time talking about accomplishments and their impact and delve into priorities and strategies. I feel like I have to have a disclaimer to start. We're a pretty big operation, and it's challenging to be all-inclusive. I don't want anyone to be insulted if their particular niche is not glorified on a slide. It still counts and it still matters, but there's a lot I'm going to cover in a fairly brief amount of time, and I still want to allow for some questions too. And, you know, when it comes to priorities and strategic initiatives, it's really challenging to be all-inclusive in that too. It doesn't mean that all the work we do isn't important. Some things are going to happen only under this roof, known only to us. Others, more likely, are going to require a lot of partnerships and collaborations. Some are going to actually have the interest of the governor and the legislature. And not everything can fit all into those categories. I got a little advice from Howard Koh, who was once the Commissioner of Health in Massachusetts and then became the Assistant Secretary for Health in Washington, and a bunch of others, and they basically told me, in any given year, you can only have 1, maybe 2 major things you think you want to get done. Well, this presentation is going to break that rule for sure, because we must be visionary, and we must really be passionate about the things that we are doing, but we have to be a realist as well and know that not everything is going to get done. But having said that, I want you to know that I'm trying to be visionary and passionate, and I'm not trying to be crazy. So with that set of qualifiers, let's move ahead, starting with accomplishments and gratitude. We did a lot of work over the last year in preserving our children's brains. Everybody's well aware of the lead in drinking water efforts. And it's an ongoing process to allow us to make sure that every child care and every independent and public school in the state gets tested and, where needed, remediated. A trio of laws to combat the vaping epidemic, which I'll show in a little bit. We really have people in state government, not just those in the specific health committees, but from the governor to abundant legislatures, really understanding this necessity to build resilience and to prevent toxic stress. And we even have a position that's been designed in the Agency of Human Services to accomplish that. And then the Opioid Coordinating Council sort of sunsetted, and arising like a phoenix was the Substance Misuse Prevention Council. We actually had our entire state, what? Help! I just pressed buttons. Our state health assessment was completed, and our state health improvement plan was completed and published. And it used to be that we started with the downstream, which is where the healthcare system works, taking care of chronic diseases, trying to counsel people about risky behaviors, etc., and improve people's life status, and working on their social determinants or their living conditions, where they live, where they work, where they're educated, etc., used to be called upstream. But now it's really midstream. So there's a big focus on the social determinants in our state health improvement plan. And then upstream now becomes our whole health department-wide issue of making sure that we have health equity. And we'll cover that a little bit more at the end of the presentation. We've had some very huge ongoing education efforts, and this only nibbles at them. Obviously, lots of substance misuse campaigns for messaging, the new Let's Talk Cannabis part of our website, the epidemics of vaping and E-Valley, E-Valley being e-cigarette and vaping-associated lung injury, lead and PFAS and other environmental hazards, and lots of stuff on vector-borne illness. I wish we could do more than just educate on that. Plenty of stuff going on with the opioid crisis, which any health commissioner in any state has to really have as front and center. Ongoing and future efforts in stigma reduction, which is huge. A real plateau in our overdose deaths. The advent of rapid access to medication-assisted treatment, which I'll speak about a little later. Lots of impacts on the continuum, prevention, intervention, treatment, recovery. Workforce development issues. Partnerships with housing and employment, because without those, recovery is meaningless. And then we'll say a little bit about what's been going on with hepatitis A and hepatitis B, because we are actually in the midst of what we will call an outbreak or epidemic, because we're seeing way more than the usual number of expected cases. And some of that has been going on already. A bunch of stuff going on from the immunization side of things with our youngest children. Then when you look at the teenage years and the HPV rates, you might go, oh, whatever. Doesn't look super astounding, but when you start looking at 50 states, these are incredible numbers, and they will get better even. And then most importantly, there's been a big focus because of the measles outbreak nationwide on what's going on in school-age children on their required vaccines. And from 2012 to 2018-19, the graph is very nicely ascending to a level of almost 95% of all of those K-12 students being up to date on their required vaccines, which is huge. And then we have incredible recognition across the state, not just state government, but across the state, and credibility because of what we do with data support and analytics support, our COOP and other emergency planning. We actually had 2 HOCs concurrently this year. One was due to the magnitude of work that the lead in school drinking water required. The other was for the vaping epidemic. But as you can see, DEPREP, environmental health, EPI, you name it, all parts of the health department were front and center. We're very much recognized for our communications expertise, and it's coveted because what you may not know is there's really no other part of the Agency of Human Services that has that level of communications expertise. So people want to steal it all the time. Similarly, our IT brain trust has actually been stolen much of the time, but it's slowly returning back to us as well. We're regarded as experts in health policy development and often in writing legislative language for the legislature, and our performance improvement and performance management strategies that you're all well aware of. So, public health was once just stamping out epidemics, making sure the environment doesn't have too much toxicity to us, and preventing chronic disease. And it still is all of that, but it's much more now what we as a society, not just what we as public health, can do to collectively assure that the conditions in which all people can be healthy, and forming all of these intersectoral partnerships and collaborations. And speaking of those, there's an unprecedented level of collaboration going on under this roof right now, which I really think we all should be recognizing and proud of. There's also a fair amount with the Office of Local Health statewide, not a fair amount, a tremendous amount. And then across our Agency of Human Services, I just put a few of the things that we're actually very actively engaged in with everyone. DOC with their efforts to provide MAT for anyone who needs it. Their programming on hepatitis C vaccination, and more recently, even hepatitis A vaccination that we're coordinating with them. With DCF, you're going to hear something about Strong Families Vermont soon in the presentation. With DMH, suicide prevention efforts, and a joint report that was just filed with the legislature. With Dale, I'll be talking in this presentation about all of the things I showed on that slide, and then ongoing healthcare reform efforts with DEVA. So that's just a little bit of what's been going on here. I wanted to recognize our stature, which I've tried to downplay because this is just one organization, though it's respected. It's been doing it for 30 years. They thought it was a big deal. They're going to come out with even more press about us. We've always been in their top grouping, but it's nice to be number one. But just recognize it's a curious process that they go through, which I will not perseverate on, but just show a little bit about. So they have two sets of rankings, Determinants ranking and Outcomes ranking. We were number one in Determinants, number 6 on Outcomes, both very respectable. And they put a gemish together, and you still come out number one. So how did we do that? Well, in health behaviors, they really called out tobacco control efforts and all of the measures we use in our 3-4-50 strategy. Not so much drug deaths or excessive alcohol, where we didn't do as well, but obviously not so poorly that we didn't get number one. The community environment set of determinants was things that you might not think the health department does with its time, like focus on keeping our air clean, our children out of poverty, and our crime rate low. We do collaborate in these areas, and we do have influence, but obviously this is where it takes a village as opposed to it takes just the health department to be the one leader in that. Low incidence in chlamydia. They weren't so impressed with pertussis, though the year they looked at was an up year for pertussis, and we actually have very up and down progress with pertussis. So we shouldn't actually feel offended by that. In the policy area, they called out immunizations and per capita public health funding, which I think came out to $144 per person in Vermont. Doesn't sound like a lot of money, but that's about wonderful when you look at the United States, which puts almost no money into public health funding, less than 2%. And then they looked at our percent uninsured, which I think we're probably just second to Massachusetts. So we came out very high there. And then in clinical care, we got kudos for workforce, even though we do have an aging workforce that we're really nervous about. They didn't like dentists as much, but I have to say we're still in the top half with our aging dental workforce that's aging just like everybody else. And then percent low birth weight, which we traditionally have a very low percent of low birth weight. And then in the outcomes area, I only listed a few, but reducing health disparities, we hadn't even launched the ship, and we're already leaders in that in the country. So we're setting the bar really high. And then infant mortality rate, which we've always had, is very low as well. Cancer deaths, they called out. We have a competition with cardiovascular disease and cancer that any given year it could be one or the other, and they're very close together. I wouldn't make as big a deal about that, but obviously we're not going to ignore the fact that people are dying of cancer in Vermont as we strategize. So that's sort of a brief glimpse at our number one. We can applaud ourselves and move on. So now I want to get into the part of the talk about what are the things I'm passionate about and priorities. And you might say, well, how does he even come up with this? So this is not a ranked list. This is just throwing on a slide what I thought about. The burden of suffering, I think, should be on any kind of approach. We want to address things that are pretty big in public health. Statistics that we look at and go, oh my God, what are we going to do about that? And we always have a lot of those statistics, in spite of the fact that the United Health Foundation thinks we're number one in so many things. Areas where there are clearly disparities and where we know inequities exist, and we say we need to correct that. Always have to be cognizant of our political leaders and where they can be helpful to us and where they can align what they're interested in, and we can align what they're interested in with the work that we want to do and our mission anyways. It'd be nice that most of the things we would do would be evidence-based public health rather than just emotional responses. Vaping is a good example of something comes up and we better deal with it. Lead in the drinking water. Resource availability. My experience as a physician does influence things. I can't hide that. And then you, in terms of not the advocates out there in the world that are advocating to us all the time, but you as advocates for what you do and what you think I should be talking about. So these are the slides that are going to break things down for us, and hopefully at the end you won't say he's insane. So priority, and these are not, these priorities are not prioritized. Okay, so don't think that if your priority was number 5, it's not really at the top of my mind, because these are just the priorities. So we're going to start with the tobacco issues and e-cigarettes. So everybody knows why we're concerned about these things, and when I show you some of the YRBS data, you'll be even more concerned because about 50% of our high school youth basically have told us that at some point in time they may have used these, and maybe half of those would say more regularly in terms of in the last 30 days. We know that there's a potent lethal combination of having something you don't think is harmful and being attracted to it, and these are not looked at as harmful. So hopefully the epidemic of lung injury may color that a little bit, but we're hearing from inside sources in the schools that not so much. The power of flavors, really important, and as you know, things have happened in Washington very recently to work on the power of flavors. I'll just do an editorial thing here. So everybody recognized that fruity flavors were what the kids really wanted. Mangoes seemed to be number 1. So get rid of those. When you get rid of those, then everybody wants mint or menthol. And so mint then became number 1. So the most recent move by the administration in Washington was to eliminate everything except menthol and tobacco flavors. So that may do something, but it's probably not going to be super effective if menthol is an appealing flavor. And we know from the combustible cigarette experience that it's a very attractive flavor, eases initiation, makes it harder to get off of these things, and they're going to find new data in the future that would actually show that. But they used some data that showed that mint and menthol often were classified together, so it looked like students were attracted by both. They had one survey that actually separated them out, and mint actually looked way more attractive than menthol, so they pivoted on that one survey, ostensibly because they didn't want to injure those adults who are using these to try to get off of combustible cigarettes. Not always the best logic, but that's where it settled out. Youth actually, when you look at surveys, like the Truth Initiative, I believe, don't always understand that nicotine is even an ingredient in the liquids that they are vaping. And because the nicotine component is so strong, the addiction happens quickly. before they actually do understand it. So that's problematic. We know that if you smoke a regular cigarette, there's tar and lots of bad things that are going to give you bad diseases. We don't know as much about these, but we know there's a ton of chemicals, like formaldehyde and others, a lot of contaminants, metal fragments, things that you don't really think should be in lung tissue. And these are also new that we don't have long-term studies yet showing the harm. Youth have been able to access easily. You'll see some data from YRBS about co-addiction with THC. And then the pricing has been attractive. So we got some great things done in the legislature last year that we were front and center on. Putting a tax that would make these equivalent to the taxes on regular cigarettes. Restricting internet sales, essentially eliminating them. And Tobacco 21, which the federal government actually just went prime time with across the country. But it will take the country a long time to figure out how to do that, whereas we're already doing it, which is great. So how can future legislation protect youth, prevent addiction, and be crafted with a health equity lens? Ban flavors and mint and menthol. So this is a great exercise in health equity because when you say ban mint and menthol, and it turns out that there are certain groups that really like these flavors, people attack you of attacking these groups, whether it be youth who like them, females, African American, LGBTQ, and it turns out mental illness as well. Our stance, of course, is that from a health equity standpoint, why don't these people have the same opportunity to be as healthy as everyone else, rather than we're going to be discriminating against them by getting rid of what they enjoy. And we'll see how that goes in this current legislative session and with the governor, because they're all front and center on thinking about what we can do. I am going to just put an aside here. Nothing I'm going to show you today actually is going to be definitive about what either the governor or the legislature is saying yes or no on. It's all coming together over these next few weeks. There will be something for sure. So that is that experience. The next priority is strengthening Vermont's families, building resilience, preventing early childhood trauma, and a better future for all. Is that all? And it's a cross-cutting strategy, really, across everything we do here. So what are we talking about? Well, for kids, we're talking about, obviously, childhood development, communication skills. Are they ready for school? For mothers, and I put mothers, not just parents, because it's actually better proven for mothers and the mother-child dyad than anything else. But parenting skills, the need for interventions with birthing, overall health, that goes for kids and the parent, the whole issue of breastfeeding and maintaining that and being confident about breastfeeding, psychological status, substance use or misuse status, etc. And then when it comes to the family, is the home environment safe, and can the family be economically self-sufficient? So these are huge, big issues that one doesn't dissolve away with one piece of legislation or one public health initiative. Nonetheless, we are going to do that. So obviously the focus is going to be on this dyad, multi-generational, and as we do in public health, enhancing protective factors to strengthen families. We have less than 6,000 births per year in Vermont. You would think you can get your hands around that, and if you did even nothing about all the kids that are still living in Vermont, just started with each year of kids being born, you could make a lot of progress. So the vision, and I'm going to distill a lot of complex thinking and a lot of thousands of hours of people meeting together into just a few comments. Almost all kids, 95+% of newborns in Vermont, see a pediatrician multiple times in their first year of life. So they are connected with a pediatric medical home. Many of those medical homes, and soon an increasing number, will have a family specialist who is part of the office structure who can screen new parents through a program called DULCE, which is Developmental Understanding and Legal Collaboration for Everyone, which doesn't actually say what it is very well. But it's a program to really identify all the issues that were on the previous slide and connect people to resources. And the resource connection is already established in Vermont. It's Children's Integrative Services, CIS. The vision going beyond that screening effort is that for the parents and families who need it, there will be access to sustained evidence-based home visiting. Now, predominantly this involves the Medicaid population, which will be about a quarter of that, and we need to be able to be sure that those families can receive the sustained visiting we're talking about. Some of them will actually have nurse home visiting because of their particular needs. Others may require, I'll say, a less intensive family support home visiting program. Those programs are well shown to, in an evidence-based way, return investment very well. For every dollar spent, $3 to $5 return. And the things that they've been shown to help, we're collaborating with DCF because child maltreatment is a big impact factor, but also parental substance use, child health and school outcomes, family economic self-sufficiency, the kinds of things that feed into ACEs and that we want to prevent. So that's the vision for that, and we think we've catalyzed some genuine interest that will carry through this session. Now, I'm going to combine this priority a little bit with the preceding one because there's going to be some YRBS data I'll show you on substance use and psychological status, but also PRAMS, which is the pregnancy, risk assessment monitoring system, and how that interacts on maternal substance misuse, which really is part of the previous priority, but I wanted to combine the two here. So, if we look about smoking during pregnancy, adolescent women who are pregnant and young adult women who are pregnant, over 50% of them say they have smoked. Less education, multiracial, racial status are significant in those factors. But looking at more overall data, 24% of women smoked in the 3 months prior to pregnancy, 15% in the last trimester. Alcohol, the rate is extraordinary before pregnancy and during pregnancy, knowing about fetal alcohol syndrome and other adverse outcomes, even though they were advised not to. Marijuana use, this is 2018. I shudder to think what it will be in the future, but substantial rates as well. So that's why that feeds into the previous priority and initiatives. But moving to the current one, let's look at youth. YRBS data hot off the press. We're still doing great with cigarettes. Down, 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 down. E-cigarettes and vaping products, significant increase. This is past 30-day use. Alcohol had come down over time, not hugely, but some, and it's sort of bumped up. Now it's back here. No statistical difference between this point in time and a decade later. Same for marijuana, but clearly you'll see that in the last 3 years, the trend is this is going up. 27% past 30-day alcohol use, marijuana use. And how did they use it? Well, used to be they only smoked it. But just in 2 years, the number of smoking went way down, and the number of vaping increased eightfold from 2% to 17%. So a convenient new vehicle to consume cannabis with. If that isn't enough to worry about, everyone in the country is sort of worried that we're poised for a stimulant drug epidemic. And indeed, Vermont has some notoriety because we ranked #1 in these years for past year cocaine use in the young adult age range. Fortunately, methamphetamine remains low and not significantly different than the U.S. But cocaine is significant concern, especially when you realize that the cocaine of today is actually not pure cocaine. It's frequently mixed with fentanyl, which is why the number of stimulant-related fatalities have increased over these last couple of years, coincident with the epidemic in fentanyl. The blue is cocaine, the maroon is prescription stimulants, so it's mostly cocaine we're talking about. But that's a significant problem to the point where we're developing strategies now specifically addressing stimulant use, as if having an opioid crisis wasn't enough. So when I put all that together, you come up with Iceland. That's an oversimplification, but really everyone in the state actually identifies with something that's on this slide now, because I think we've done a lot to advertise it. So clearly we have our traditional messaging campaigns that are always important. They're necessary, but never totally sufficient. And addressing stigma is going to be an increasing focus. We already talked about the home visiting models as methods for improving resilience and reducing ACEs. We currently have school-based primary prevention programs, though need to be expanded. But the big real focus for us is in the after-school, what's called the third space, the hours between 3 and 6 p.m., which tend to be most dangerous for adolescents when they experiment with hosts of different substances, may acquire STDs or become pregnant. But it's quite well proven that if you focus on that time zone, success will follow. The Iceland model is something that, if I can distill it to one line, it incorporates surveying the youth to know exactly how bad things are, allowing youth to have a voice so that you schedule activities that actually are consonant with what they want to be doing, parental investment and activation, and actually in Iceland they actually sign something, and then the community being activated to embrace adolescence and provide a lot of this curriculum and activities. Separate from that is community mobilization and kinds of coalitions like we have, like with Project Vision, Peter, et cetera, throughout the state. And when you start researching what you can do, well, like everything, you need to focus on protective factors. So family connectedness and school connectedness really important. We do fine here. When you look at constructive use of time, that's where we have a lot of room to really expand, because adolescents are telling us on the Youth Risk Behavior Survey that they don't spend these number of hours in extracurricular activities or aren't even involved in any at a pretty high rate. Community connectedness is also an important feature. We were at 50% for a while, up to 64. Now we're at 58% in the 2019 YRBS. I'd like you to look at that as a glass half empty, not glass half full thing, because it means 42% of students don't feel they matter in their community. That's a lot of students. And if you happen to be of color or an LGBTQ, that's even more disproportionate. But look what Iceland did in 2 decades. Whether you're talking about alcohol use, being drunk, whether you're talking about daily smoking, or using 1 or more times cannabis, market decreases from 1998 to 2015. Now, you don't have to adopt a model that's called the Iceland model, which is now called Planet Youth, because we have something in Vermont called the Regional Prevention Partnership Grants. We have a framework called the Strategic Prevention Framework, and if you apply that, as it was applied in Deerfield Valley from 1999 to 2017, you come out with graphs that look like Iceland. This is their alcohol use in the past 30 days, and this is their cannabis use in the last 30 days. So dramatic results before anybody used the words Iceland and Vermont. So obviously we're trying to get a lot of traction and programming like this to have an impact in our state. Everyone's concerned about marijuana in the current legislature because the word on the street, maybe there'll be a tax and regulate system. Item number one is it's not our job to advocate for a tax and regulate system, and we have never, but we have been realistic and said if such a system of commerce is legalized, which it could be in this session, we don't know. We've had plenty of recommendations from the Marijuana Advisory Commission, the Opioid Council, and now the new Substance Misuse Council about what should be done to protect predominantly youth, but protect the public. And how important having a prevention and education fund will be, and the governor has signed on to that. He's also signed on to saliva testing, which you'll hear a lot about in the news, I'm sure. But we're insistent that there be upfront investment, because every state that's legalized marijuana and waited for their tax revenues to come in, number one, they've learned there isn't so much revenue, and number two, they've learned that they're already behind the eight ball because they didn't have the money up front to try to help people out. So we believe there should be a modest amount of money up front that will help us do the things we do well, like public information campaigns, education strategies, and a core prevention strategy, expanding these types of grants that accomplished what Deerfield Valley accomplished previously. So that's where we are in that priority. Moving on, we're going to stay on substance misuse just a tiny bit more and talk about the opioid crisis, because like I said, the health commissioner would not have a job if they actually weren't putting this front and center in their state. So I have to continue. That isn't the reason I'm doing it, but it's nice to hold on to my job a little longer. So if a state does nothing else to confront the epidemic, they have to have prescriber-focused prevention to keep prescription opioids out of the supply chain, so to speak, because they get diverted and then people acquire new habits like heroin. There has to be a focus on harm reduction, which essentially is keeping people alive long enough so that when they do come to the realization that they're interested in treatment, they're able to get treatment and they haven't succumbed to an overdose. And then treatment-focused, expanding access to MAT. So the data behind how we're doing on those three, I can do in 3 slides. Here's what happened with our Vermont pain rule that came into effect in July of 2017. Now I have to be candid, there was a down-sloping curve already in physician prescribing of opioids. This is in MME per 100 people. But if you just look here, this is when the rule was sort of being formulated, hadn't even been operationalized yet. And then all of a sudden the rule comes into effect, much more dramatic decreases, to the point where there's now a 43% decrease between 2016 and 2019. That's pretty successful. Obviously, that can't be your whole program, but that's a really good success we've had in Vermont. I'm not going to talk about naloxone as harm reduction because the bottom line is, yes, we have flooded the streets with naloxone, and we're doing well with that. The problem is when you give it to individuals, even if you tell them you want to know how it got used or if it got used, you never find out. The only time you know is if an EMS person or if other first responder used it. So suffice it to say, there's a lot of naloxone out there. We're not sure exactly what it's doing. But SSPs, Syringe Service Programs, are now kosher from the U.S. government. States like Vermont were way ahead of the curve. Everyone's always agreed they're wonderful vehicles to prevent HIV and hepatitis C and other infectious diseases that get transmitted through needles. However, no one wanted to go any further than that. But now, CDC and others in the government have confronted themselves with the evidence, which shows that you're more likely to enter drug treatment, more likely to stop using drugs, more likely to access primary care. You will have a reduction in viral diseases, and you won't have crime rate increases just because you've established these. We knew all this already, but nonetheless, It's a main part of our current strategy because these programs are so important. It's not just the exchange itself, it's the social community that that person enters. It's the case management that's going on under that roof. You're getting naloxone. You have access to fentanyl test strips if you believe those will help you in this era of lots of fentanyl on the streets. You will be screened for the viral diseases if you would like to. And if on a given day you decide you would like to enter treatment, you can be either referred or, in some instances, receive rapid access to MAT under the same roof, because that happens here in Burlington right now with a prescriber there. We'd like that to be expanded beyond Burlington. And then with regard to MAT itself, I'm not going to perseverate on the hub and spoke model, but there it is. Complex treatment centers called hubs where there are addiction medicine specialists. Methadone can be given there. It's the only place it can be given. People who really are on buprenorphine but have a lot of complex needs will also be cared for there. And then spokes being mostly the primary care offices, some mental health, some OBGYN, where people are on maintenance buprenorphine predominantly. Both settings, access to counseling and other resources. What's happened in Vermont? 2.6% of the population in 2018, 18 to 64, received MAT. We doubled the number of people between 2014 and 2018 who were getting MAT, and we totally eliminated the waiting list. So we now have access for anyone who wants it to get it in Vermont, which is a big deal because that would mean, presumably, that if you were actually on the streets and wanted it but couldn't get an appointment for 3 months, you would no longer be at risk of dying from an overdose death, in theory. So we hope our overdose death rates not only plateau but go down. So what are we doing in the future on these 3 components? Well, first of all, there's a lot of quality improvement work and technical assistance at the level of our prescription monitoring system. An opioid prescribing toolkit has been developed for clinicians. And now, on VPMS, other drugs are reported to clinicians in terms of their stimulant prescriptions, etc. In the harm reduction arena, I've told you we want to do much more with the SSPs and rapid access to medication and treatment. We have a whole new campaign being formulated on reducing stigma. And then there is this new epidemic, as I mentioned earlier, on hepatitis A and to a lesser degree hepatitis B for mostly the susceptible populations, which are those who are homeless, who may be misusing substances, or who may be in the correctional setting. And we've actually tried to immunize already in all of those places, seeking out those in the homeless communities and working with the correctional system and setting up other clinics as well. So an ongoing success story. And then in the treatment realm, meeting the person where they are with RAM, probably ready to relook at the hub and spoke structure and decide if there are further enhancements and improvements that could be made. One that comes to mind is mental health care, since it's so often a comorbidity. And then that delicate issue of people who are out there, they have not yet accessed treatment. How do we find them and how do we connect them? When I spoke at a recovery day celebration or whatever, I came up with this list of potential goals for those in recovery, and everyone in the room said that they resonated with them all. So I just show them to you to read because they really tie in with what our strategies are. You've seen the strategies on prescriber prevention, on youth prevention throughout the presentation already, and on treatment. Now we're talking about recovery, which is really another form of prevention. So bolstering up our network of recovery centers, concept of peer recovery coaches as a point of contact with someone who may be ambivalent still about getting treatment. Very powerful force, and now there's an academy and a whole certification process and a job that's not just voluntary. And then tie-ins with the recovery housing issues, and employment communities to, again, deal with actually making sure people have a life. That we're not just providing MAT, but they actually have a productive life to return to. Suicide prevention. So, little secret that we have the 19th highest suicide rate in the U.S., and then from these years, an 18-year period, we had the second highest rate of increase. It's bad enough the U.S. rate of increase was 30%, we were 48%. And the per capita rates reflect that. For elderly, predominantly male, but not all male, we're also way overboard when it comes to that. Over 50% use firearms, which of course is the most lethal mean. If we talk about just intentional self-harm, we also outrank the U.S., especially for young adults and adolescent females. And we could develop strategies that capitalize on the fact that almost half have seen a primary care physician in the preceding month. Many have had mental health issues. But then again, many have not, so that isn't the only predictor, and that's important to keep in mind. YRBS data that is upsetting to me, and this is now hot off the press as well. When asking high school students about feeling sad or hopeless, which really is every day for at least a 2-week period in the past 2 months, we're up to 31% saying yes to that. If we ask them if they made a suicide plan in the last 12 months, 13%. If they actually tried to complete a suicide, 7%. That's just extraordinary data, and you throw that together with some of the data we have in our older male population, some of whom, but not all of whom, are veterans, but that has the governor's eye and others' eye, and it's begging for strategies. So our approach is, and a nice report that just went in, that was a collaboration between DMH and our department, focusing on both youth and adults. I put this as a question mark because this is the polarizing thing, which actually, even if we didn't focus on, we have plenty of room to do good, but we don't want people to conflate everything together and just be turned off by this when it looks like we're taking guns away, because that's not what's happening. But look at what we could do. Expand and bring to scale zero suicide. Zero suicide is a platform of prevention. It's a very compulsive platform that tries to look at where the person is and where they're touched by others in the system from step to step to step. So it works on screening, it works on warm handoffs, as they're called, etc. Our Vermont Suicide Prevention Lifeline turns out to not be such a lifeline because people who connect to it are often transferred to a center out of state and have to wait. And if this is a crisis moment, waiting is probably not the practice. Mobile response and stabilization services is really a roadshow, if you will, people who can make a home visit to a family at a time of crisis and try to prevent de-escalation or cause de-escalation to prevent escalation. And then elder care clinicians, that's a program through Dale that actually works for homebound older Vermonters who may not be permanently homebound, it may just be winter in the Northeast Kingdom, but they are homebound for that purpose. And these clinicians actually can, again, connect with them, provide some of that connectivity where they're socially isolated and avert them going on to plan or even attempt suicide. So a lot of work that could be done. Stay tuned in terms of what traction this develops in the next few months. I mentioned the older suicide rate, but let's talk more about healthy aging. Health departments have been forever focused on maternal child health, and as you see, I'm happy focusing on maternal child health. We spent a lot of the early part of today's grand rounds on it. However, let's look at the other edge of the spectrum, which is where health departments have really gone before, and where now we're being called to perhaps take action. So there's a concept called age-friendly communities, and there are 5 states that have become, or maybe 4 states in D.C. that have become age-friendly states. It's a designation by the AARP and the WHO. As you know, we are the 2nd oldest state in the country. We're vying with Maine and New Hampshire for the 1, 2, and 3 spots all the time. So the concept that Monica Hutt and I came up with was called Vermont Friendly at Any Age, recognizing the aging of the population. If we were becoming an age-friendly state, it would mean considering these 4 bullet points. To get more specific, it really is all the things that we want to do in our state health improvement plan. Walkable streets, housing and transportation options, working on services and opportunities so people can be active in their communities. And then looking at the aging population specifically from the lens of environment, economic, and social factors that influence health and well-being. Now, the concept of this is that, yes, this will help the old, but it will help everyone when you're helping those that you're focusing on as being older Vermonters. Likewise, if you're a governor who wants to bring people into a state and your workforce plan is attract people to Vermont, what better way than to say, we are really focused on the age continuum, and we can actually look at all of those factors, and you will benefit from them when you come here to start working, when you start raising a family, and then you could age in place here as well because we've already considered all of this approach. A nasty part of our elderly portfolio is we're practically the tops in falls, and we know how bad falls can be in terms of predicting future morbidity and, unfortunately, mortality. We have one injury prevention person in the audience today. Let's see. Okay. There you are, Tanya. And a very small portion of that person is dedicated to falls. Dale, unfortunately, has the same small component. So this needs resource development. And fortunately, forgetting just falls, but the whole healthy aging concept, our SHIP says community support healthy aging and healthy living. Our state plan on aging says primary goal is to support healthy aging for all. And these are the kinds of initiatives that we talk about. So this is all consistent with that program I mentioned. Now, early on, that program actually doesn't even cost any money because it involves a lot of upfront planning and getting partners to the same table. But over time, it does require some investment. Just like the State Health Improvement Plan and State Plan on Aging would require investment. But all of these concepts are very important things that we've talked about here that intersect numerous other initiatives that we're already talking about today. So our hope is that the governor is very close to at least saying he will send a letter that requests that we become an age-friendly state. But I can't make you that promise yet, but it's close. I'm a general internist. How can I not still focus on reducing obesity and chronic disease? Julie was getting a little nervous in the back. So just quickly, our obesity rate, we're better than the country, as always, and that's fine. 27.5%, 8th lowest in the nation, and we have a rapidly expanding, if you know what I mean, population of obese people. When we look at youth, this is now YRBS, so youth are reporting their height and weight, and we're calculating their BMI, and it's pretty reproducible year to year. I mean, we rely on this. It has a high reliability factor, I would call it. Pretty stable there, and 10th lowest in the nation. If you look at a different survey, though, the National Survey of Childhood Health, this is actually reported by parents, not by the youth themselves, and it's a smaller sample size, and it's a totally different survey, but we don't look good on it. And in the news a couple months ago, this was called out and got a lot of people around the state very nervous. Notice, though, that The YRBS is grades 9 to 12, and this survey is age 10 to 17, which calls into play the earlier part of this age range as maybe being an issue. So we still have to be cognizant of the fact that these kids are our future adults, and childhood obesity is really the thing that nationwide people are trying to work on hardest. If we look at our physical activity for our youth, basically half the youth, say 5, 6, 7 days, that they're physically active, not even half, more than half aren't. When we look at their fruit and vegetable consumption, 31% eating 2 or more fruits a day, 19% eating 3 more vegetables a day. If you adjust the number, you'll come up with a different percent, but we can do better nutritionally as well. So how do we do that? Obviously, everybody knows the Freedom Health Pyramid, where from a public health standpoint, as opposed to where I used to be in my career, we are now here all about making the individual's default decision the healthy decision. You ban trans fats. Well, you can't buy a cracker with trans fats in it, so we've made your default decision pretty healthy by that. And we try to do that with our smoking laws as well. And then working on social determinants. And from a Vermont prevention model standpoint, we know we can do a lot of good work in this arena, but we spend a lot of time on the organizational level and community and policies and systems level. And that's our 3-4-50 program. So if you want to be specific about the 3-4-50 strategy, it's now in a public-private partnership with RISE Vermont. And what's it trying to do? It's trying to do what we do in public health. Work at the business or workplace level, work at the school level, child care, municipal planning, all the behind-the-scenes work that we do. RISE Vermont tries to make it a little more portrayed on the public level in terms of group activities and fun times in their communities, but that isn't enough to sustain an effort. The effort really has to be making those default decisions, the healthy ones, which 3-4-50 really does well at. And then lastly, the whole continuum that I mentioned early of our SHIP, health equity, social determinants, health in all policies, accountable communities for health. That's a lot of words, and there's a lot of efforts going on in each one of those. But as a health commissioner, you've got to be focused on this, and you've got to be passionate about it. I illustrated a little bit earlier about how this plays out in terms of the midstream and the upstream. And then our very busy slide on our strategies will close this out, because really we're talking about investing in policies and infrastructure that create healthy communities. So we have a Health in All Policies task force around the state, our growing community collaboratives and accountable communities for health. We have community health profiles. But what are they trying to do? Really heavy lifts that you can't just do in 1 month. Implement policies and promote norms that encourage physical activity and healthy eating and discourage tobacco and drug use. That's 3-4-50. Well, 3-4-50 takes years of real hard work. Expand housing and weatherization. Some people think weatherization is our major public health strategy in the state right now because we talk about it so much, because that's required to create this. Second set of strategies, promoting resilience, connection, and belonging. I talked about things that are going on in mental health, maternal child health, across the health department with home visiting, strengthening families, the after-school programming, etc. So this ties everything together that we've been talking to. And then where we have the integrated person-centered care and really try to do the community public health clinical connections, if you will. But again, heavy lifts. Integrate oral health, mental health, substance use disorder into primary care. Integrate oral health into other settings like nursing homes and schools and healthcare practice. So this is where we're going in our department with our strategies. And these are going to be, obviously, this is a 5-year state health improvement plan, and we have teams that are already working on some of the tactics for multiple aspects of these, not to mention the whole issue of health equity. And my last slide is just to help placate anyone who thinks they've been forgotten because there's a lot going on, and not everything, as I said, can be the highest priority, at least for the outside world, but we have to continue. Climate change, I think the legislature is going to raise that profile way up there, and we're poised already to join in with that. Vector-borne disease, whole new issue going on with a national law that was passed that should provide more money to health departments like ours. Lead and PFAS will continue. Cancer prevention, again, part of the 3-4-50. Firearm safety may rise its head again. We do a lot of work that's under the scenes with antimicrobial stewardship and sepsis, which must continue. Our immunization program must continue to do all of its good work. The nation now wants to eliminate HIV, and we're part of that, no question about it, though we're doing much better than the rest of the nation comparatively. So thank you for all of your attention. I think I used up every minute of the hour, but I do want to make sure if people have questions and have time to stay, feel free to and ask me questions, or otherwise just come up here to the front. Thanks again.